So I'm given few selected images from a barium enema series. So in this images, what I can see is there is a short segment circumferential narrowing in the mid-transverse colon with an apple core appearance, what we call as apple core appearance in the mid-transverse colon. Now this, along with this, we can also see that there are few diverticula which is present, which is filled with contrast here. So there are few diverticulas, and there is a circumferential narrowing of the transverse colon, mid transverse colon, which is looking like an apple core appearance. Based on these findings, I feel that this might be a case of colorectal carcinoma. However, there is no obstruction caused by this lesion because there is no gross dilatation of the proximal bowel loops. Now, based on this diagnosis, I would refer this case to a surgical department or the gastrosurgery department, and also I would plan for a CT, contrast enhanced CT, to look for the extent of the disease and to stage the disease. This is one more similar case in which what we can see here, there is a, if this entire thing is the ascending colon, and what we can see here is a polypoidal mass, and this polypoidal mass on a CT colonoscopy we can see it is having this saddle shaped appearance. So this saddle shaped appearance of a polypoidal lesion is a one more thing that suggests towards colonic malignancy. So this presence of this kind of polypoidal lesion, or if there is a pit in the polypoid or the depression in the polypoid or a flat polypoidal lesion, suggests more towards a malignancy. Now if you see colonic strictures, there are causes of colonic strictures can be ischemic colitis, diverticulitis, or any extrinsic compression other than the malignancy. Also, there can be some inflammatory pathologies like Crohn's disease, which can cause long segment strictures. Now, ischemic colitis will also cause us long segment stricture. Diverticulitis also causes long segment stricture, but ischemic colitis will have classical thumb printing sign, and the diverticulitis we can see the outpouching of the lumen of the colon, and it's usually the both ischemic colitis, diverticulitis, Crohn's, all of these will have long segment bowel strictures. Now, extrinsic pathologies can be any mass which is present outside. It can be an ovarian malignancy, endometriosis, or it can be any metastatic lymph node. These all things can cause compression, and but whenever they cause compression, they will form an obtuse margin. So if I say that this is the colon, now if there is an extrinsic compression on it, like this, so the margin that is formed here will be an obtuse margin. But if there is a lesion within the colon, then usually it will form an acute margin. So based on this, we can identify whether it is an intracolonic mass or it is an extraluminal mass lesion. So this is how we identify different types of the colonic strictures. So there are different causes of strictures. So to identify what is the real cause of strictures, whenever we see a stricture, we have to see following things. Now, the first thing is we have to see where is the site of the lesion. Now, some strictures, for example, the strictures in the areas like watershed areas, then it possibly will be favoring towards ischemia. Now, also we should see the configuration of the colon, that is whether it has any previous surgery or whether it is a previous site of anastomosis. So this site will help us to identify why the stricture has come. Also, we have to see the length of the stricture. Now, if it is long stricture, then it usually favors towards diverticulitis, ischemic stricture, or colitis, which is responsible for the stricture. But if it is a malignant stricture, then it will usually cause a short segment stricture. And one more thing that tells this is malignant stricture is irregular, very rough surface. That is what we see in case of a malignant stricture. If it is smooth, it favors towards a benign stricture. Now, once we see the stricture, also we should see whether the stricture is tapering or it is having shoulder. If the stricture is tapering, like this, it favor towards the benign conditions. But if it is having shouldering like this, then it favors towards malignancy. So this is how the transition we should see. Also, if you see if there is any presence of diverticula, which again favors towards a diverticulitis causing the stricture. So once we know that this stricture is because of malignancy, you also look for, is there any other synchronous lesions, or is there any other polyps, because some polyps are the risk factor for colonic malignancy, some are familial polyps, and some are syndromic, which will have other malignancy. So it is always important for us to see, is there any polyp, is there any synchronous lesions. Now always we need to check, once we find out there is a malignancy, then you have to see the extent of the lesion. And once we see the extent of the lesion, what are the problems caused by this malignancy? Is it causing obstruction, is it causing perforation, or is it invading the adjacent structure? Now once we do that, we should see again the extent. When we have to see whether the bones are involved, whether the distant metastasis is disease present, or whether it is only local lesion. Now again, as I told before, whenever there are polyps, we should see whether it's a saddle shaped polyp, whether there is a central depression, or whether it is a flat polyp. Now this all favor towards a malignancy, suspicion of malignancy. So this gives us some other causes of the large bowel obstructions. Now the large bowel obstructions, the common causes includes, one is malignancy, which is the most common cause. Then it can be volvulus. The volvulus can be from sigmoid, can be from cecum, or can be transverse colon, because all three structures can be moved. So these are the mobile structures, have a high incidence of going into the obstruction. Also diverticulitis, specifically in the sigmoid colon, the diverticulitis is a common condition, and it will lead to stricture formation, specifically long segment. So whenever we see long segment strictures, we think of diverticulitis, any inflammatory conditions. Uncommon conditions includes intussusception, specifically in children, or if there is any polyp present or any lead point has to be created. It can be any lesion which is present, then intussusception is common. Hernia can cause obstruction, as I told. Inflammatory bowel disease like Crohn's disease can cause obstruction, or extrinsic compression like a metastatic mass or an abscess. Also, fecal impaction or intraluminal foreign body also can cause obstruction. Now we'll see some of the cases of obstruction in a fast review. So in this X-ray anteroposterior supine abdominal radiograph, what we can see is, here there is a dilated transverse colon, dilated descending colon, but at this point, at the inferior aspect of the descending colon, there is sudden cutoff of the colon, and distal to it, we are not seeing any rectal gas. Or we are not seeing any sigmoid colon. That suggests that there is an obstruction at the distal descending colon or the proximal the sigmoid colon. So in this image, what we can see is, here the cecum is grossly dilated, but there is gas in the distal colon, that is the transverse colon, the descending colon, ascending colon. All of them have air in it. So this is a CT scout radiograph image which is showing distended cecum with air within the transverse, ascending transverse and descending colon, and even the rectum. So this is a case of cecal ileus. So there is no obstruction, but because of cecal ileus, that is the non-obstructive dilatation of the cecum is what we see here. And this is case of cecal volvulus. Again, we can see a dilated cecum here. Now this is a case in which the patient was paralyzed because of pontine hemorrhage, and we could see that there was distension in the abdomen. If you see the x-ray here, APV is given, and right lateral decubitus x-ray is shown here. In both images, if you see here, we can see there is grossly dilated bowel loops. So this is also a case in which there is no active obstruction, but because there is no, the patient is paralyzed, the bowel loops are dilated because of no active motility, more like an ileus condition. So it's not always when there is air inside the large bowel, it is not always an obstruction. So it has to be well understood that dilated bowel loops not always an obstruction. We should also see for other point like a transition point or any other signs that are showing us the cause of obstruction. So this AP radiograph, if you see that, we can see that the transverse colon is the dilated, distended, and suddenly we can see a transition point here. Now the corresponding CT images, if you see that the descending colon is filled with the fluid and some matter, and then if you see this, there is thickening of this descending colon with enhancement, and there is a break in the continuity of the wall. So this is nothing but a case of colonic carcinoma. So this is a colonic cancer now with break in the wall, that is nothing but perforated colon cancer is what we see here. So this is one more case in which we can see that there is a grossly dilated bowel loop which is folding itself. It is appearing almost like a coffee bean appearance. So this is nothing but a sigmoid volvulus which is displacing the transverse colon and the ascending colon towards the right side. What this appearance is called as a northern exposure sign by the sigmoid volvulus. Now in this image again we can see that this classical coffee bean appearance of the sigmoid volvulus. Now one more classical sign that we see in a CT is this whirlpool sign. We can see that there is the blood vessels. If you continuously scroll, the blood vessels will be rotating around each other. Also this appearance where it is the bowel loop is appearing to the twisted here. Now this is what we see at the pedicle of this volvulus, and we can see that fecal filled distended the transverse colon, ascending colon, because of the obstruction is what we are seeing. Again a case of sigmoid volvulus with coffee bean sign and whirlpool sign. This is a barium enema study, selected images from barium enema study, and what we can see here is distended the rectum, and we can see there is a bird beak appearance because of the twisting of the sigmoid colon, what we classically called as a bird beak sign. Now in this image what we can see is a similar appearance as that of the previous. We can see that there is coffee bean appearance, but this time the coffee bean, the pedicle is facing towards the right side, and we can see a whirlpool sign towards the right side. The coffee bean is facing towards the left upper quadrant. This is how classically a cecal volvulus presents. We can see this fecal filled cecum which is twisting on itself, a classical image of a cecal volvulus. Now in this image again we can see that there is distended, air filled distended, the descending colon is present. Suddenly there is a transition here, and now if you see this picture we can see that there are few outpouchings from this sigmoid colon. Also we can see that there is some enhancement in the wall of this colon. We can see patchy areas of enhancement everywhere we can see. So this is nothing but inflamed sigmoid colon with diverticulum, and there is free fluid around this bowel loop, this free fluid here. So this is a classical case of inflamed bowel loop with diverticulum, nothing but diverticulitis with surrounding inflamed the mesentery or the peritoneum, or with the fluid collection around it. It's a diverticulitis causing obstruction. Usually we can see like this long segment obstruction, what we classically see in an inflammatory condition, unlike malignancy. So in this again we can see that the obstruction is at the level of transverse colon, the proximally it is dilated, distal we are not seeing any air, and if you see the CT images we can see the bowel within a bowel appearance. So this is classical of intussusception. So this is an example of, so this is the fecal matter which is causing the obstruction, which is causing dilatation of the proximal bowel loop. This is a classical case of fecal impaction. So it regularly in a old age patients or a psychiatric patients, this is very called dehydrated patients, very commonly seen the fecal impaction, can also present like obstruction. This usually doesn't need a surgical management, so it is very important to identify this. Now this is again one more case in which there is herniation anterior abdominal wall, through the anterior abdominal wall, which is causing obstruction and dilatation of the proximal bowel loop. So hernia can also cause obstruction of the bowel loops, specifically the large bowel loops can also be herniated. In this slide again we can see that there is obstruction at the level of the descending colon. Now if we see here again we can see that there is inflammation in the wall, and there is long segment inflammation in the wall. Because of the enhancement we can tell there is an inflammation. Also we can see obstruction, long segment enhancement obstruction favors inflammatory condition like Crohn's disease. So that's what is causing obstruction here. One more cause of the large bowel obstruction. Now in this image again we can see the transverse colon is dilated, and we can see presence, that is the obstruction of this descending colon. Now this was a case of adenocarcinoma of the lung. So in the CT we can see some multiple necrotic lesions with peripheral enhancement, central non-enhancing area. So these are nothing but the metastasis from the adenocarcinoma, what is causing compression and obstruction. So this is an external compression which is causing obstruction, what we can see here. Now this is a case of Glyph syndrome or acute colonic pseudo obstruction. So whenever there is no mechanical obstruction, sometimes if there is condition where there is dilated colon but there is no mechanical obstruction, this is called as acute colonic pseudo obstruction. This can be simply managed by a rectal tube, and it will relieve the obstruction which is causing here. It's not really an obstruction, but the fecal matters failed to pass because of the failure of the peristalsis, which can happen because of various conditions. Now, these are some of the causes for the Glyph syndrome. It can be trauma, it can be inflammatory conditions, or different other conditions are responsible for this mechanical, non-mechanical obstruction of the bowel, or the Glyph syndrome, or the pseudo obstruction.